Good evening, everyone, and welcome to tonight's edition of the IMA Weekly Show. Our episode is titled How to Starve Cancer, a conversation with Jane McLelland. Tonight, we're diving into a subject that has transformed the way thousands of patients think about cancer, the metabolic approach, how our cells use energy, how cancer hijacks these pathways, and what patients can do to take back control. Before we bring on Jane, we want to begin with a powerful story. Earlier this year, we featured a segment with Dale Atkinson, who recovered from stage 4 esophageal cancer. His journey is a profound example of hope, perseverance, and the power of metabolic understanding. So let's take a look.
My entire 9.2 plus centimeter tumor and all of my metastases had vanished.
Physicians should never ignore symptoms that are persistent.
The persistent symptoms were across around 5 or 6 years and also across 3 different GPs. And they all decided off the back of that, they thought I was too young for cancer. So from the freedom of access request that I put in for my patient notes, we believed there was a secondary on my aorta of around 3.6 to 4.2 centimeters. We also found one on the neck of my pancreas, and there was a number of lymph nodes involved as well. We believe there was upwards of 8, possibly 12. Because they had given me less than 12 months to live, or they told me within that meeting that they felt I had less than 12 months to live, that form of chemotherapy, they told me would lower my quality of life and only extend my life by roughly 2 months. So at that exact point in time, I decided and resolved myself to declining chemotherapy. Dr. Amanda King, her knowledge, her intelligence, and her emotional ability to deal with people in their state as well is beyond anybody I've ever met. And I cannot thank her enough for everything she has done for me.
Each person's protocol is going to be different because we have individual differences. It wasn't simply throwing figures at the wall to see what would happen. It was tailored to his blood results.
I went from struggling to even be able to get down a glass of water to, within the space of roughly 6 weeks, I went from not being able to swallow water to actually being able to eat proper actual food and be able to swallow it without being in extreme amounts of pain as well. My entire 9.2 plus centimeter tumor and all of my metastases had vanished. No surgery, no anything. I am now awaiting a PET scan to confirm if I'm now no evidence of disease. My oncologist has gone from quite literally laughing in my face about my off-label drugs and my vitamin regime, my use of a naturopath, etc., to actively discussing it with me and to asking exactly what I've done and if I can provide her with any articles around it as well.
So I think Dale's story is very powerful because I think it illustrates the power of an alternative approach to cancer therapy, which is what we're going to talk about today with Jane. So tonight I'm joined with someone whose work has helped countless patients that find the same sense of empowerment, Jane McLelland. So at this point, I must just interject and say that it was actually Jane's book and an interview with Jane that got me on the current path that I'm on. I saw an interview with Jane and I was absolutely astounded. I'd never heard of repurposed drugs and starving cancer. It was not what I was taught at medical school. It's nothing that I knew. And so I read her book, which was fascinating. And so I have to thank her for setting me on the journey that has become fascinating and that I'm currently on. So Jane is the international best-selling author of How to Starve Cancer. And so the title is really very apt because that's what we're going to talk about, how to starve cancer. A long-term survivor of stage 4 cancer and former chartered physiotherapist. She's recognized globally as a leader in cancer healing and education. Her book has been translated into 15 languages and was voted best book of all time by the Book Authority and Amazon readers. Although apparently in the UK, Amazon aren't so fond of Jane anymore. So, welcome, Jane. It's really an honor to have you with us. And with that, I'm going to hand it over to you. I think Jane's going to do.
Thank you.
She's going to speak a little bit,
Thank
some
you.
slides, and then we'll have a conversation.
Great, super. And thank you so much for mentioning Dale's story, because he's actually, he's become a close friend of mine, and we're actually starting a charity together called Beyond the Standard, which is obviously looking at anything which is going to assist, and mostly repurposed drugs. So focus will be on repurposed drugs and trying to encourage collaboration between the traditional oncologists and integrative oncologists, longevity doctors, functional medicine doctors, anyone who can prescribe, even GPs who can prescribe these medicines, because it's not just the domain, it's not the exclusive domain of oncologists to determine what you should do when you have cancer. And I think they fail to understand that point. Things have changed since, certainly in the UK in 2015, they brought in the Montgomery Rule, which then focused on patient-centric care. And this is a big change. But thank you for mentioning Dale, because I've been in the background just watching what he's doing. So Amanda's been mostly involved, and Dr. Harry Coohan in the UK, who's a doctor I work very closely with. This is the future. We know the future is going to be a collaboration between these doctors, but at the moment there seems to be an awful lot of conflict, resistance to the whole approach, and this is one of the big problems, is trying to overcome what we have at the moment, which is patients hiding what they're doing from their oncologists because they're worried about being judged. And I think that's a terribly sad state of affairs that we have. How can you get better without having an honest conversation with your oncologists? And we need to wake them up to the power of what these off-label, these repurposed drugs can do. So that's been my mission for many, many years. And my book, my first edition of my book came out in 2018. And I'll just quickly talk about my story. I don't want to take over. I know that we want to have a chat at the end as well. So we'll leave some time at the end.
But Jane, your story is a fascinating story. I think the listeners would be interested. So you can tell us your story.
Okay, because I don't know that everybody knows my story. I know I've sold a lot of books, but I guess there's a lot of people who probably never heard of me before. So I will start at the beginning. Fine, so quick disclaimer at the beginning. I'm not a doctor, not a pharmacist. I describe myself more as a patient researcher, and I don't want to discuss the dosages, particularly of drugs. That's not my job to do that. But, you must, I always insist that patients get advice from a doctor. There's an awful lot of patients out there kind of doing it on their own, which I kind of understand, but really you need to get a doctor involved. So me, former physiotherapist, as you already mentioned, stage 4 survivor. I'll quickly run through my story. I have been invited to study a PhD at Birmingham University, which I'm guessing I should do. But it's going to be trying to collate a lot of information that is out there already, because I've had a long history of being out there and causing a lot of change in the oncology profession. And it's actually collating and curating the information that we already have. We've got real world evidence of people doing phenomenally well. I've had solid tumours. And in fact, I'm just about to have hopefully a bit of PR next week with a leukemia story. So keep your eyes out for that. It'll be on my website, and it'll be on my Facebook and my Instagram if it happens. Fingers crossed. You know what press are like. Sometimes they report on things, sometimes they don't. But just to quickly talk about what I'm best known for, my McLelland Metro map is really the metabolic pathways that cancer uses to fuel itself. So it's all about trying to disturb the way that cancer gets energy, creates ATP, this energy currency. And there are many routes that it does to do that. And I've broken it down really into the 3 macros of the diet. You've got glucose, which is the carb, glutamine, which is a protein, and fatty acids being the fat. So there's a lot of focus at the moment with glucose and glutamine, and not many people focus on the fact that there are fat pathways which are involved. In fact, if you switch one of these pathways off. So the main driver of cancer is obviously the glucose, but some cancers strongly use glutamine. And if you switch both of those off, a lot of cancers actually will use the fat pathway. So some fat transporters that get upregulated as well, not on there, but CD36, for example, is particularly important. SCD1. I'm actually doing a sort of an updated metro map and a new edition of my book next year, so you'll have to keep your eyes peeled for that as well. So this was the updated one that I did in 2021, and I've also written about the progression of cancer. People don't really focus on that. They tend to focus on the McLelland metro map, which is fine, because the first thing you need to do when you have cancer is starve it. And that's this bit here. So my metro map is here. But cancer doesn't start in the genes. It actually starts in the cell membrane as a result of stimuli coming in from the abnormal microenvironment. And that leads to factors such as nuclear factor kappa beta and STAT3 being fired up. And this fires up some of these pathways in here. And once you have lactate being produced by this glucose fermentation problem, that stimulates growth factors like VEGF, the vascular endothelial growth factor, to try and take away that lactic acid. And it will also switch off the immune system as well at the same time. It'll turn anti-cancer macrophages into pro-cancer macrophages, the tumor-associated macrophages, and then you get this runaway fast cell division, which is where they use chemo, right? So this is a very basic graphic of what happens. Obviously, there's crosstalk. Once you get this going, it's a lot of mix and match going on with it, but this is a basic schematic of the classic way. I've had to unpick the hallmarks of cancer to create this map. Nobody'd done that. So, and you may disagree. You may think that's, this is not the way it happens. But for me, as a researcher, this made much more sense to me to work out how things ended up being in this fast cell division. And there are some elements here which I think are really critical. We know that toll-like receptors, which are pathogen receptors, get switched on with every cancer, right? So we know that pathogens are involved. Not necessarily, I think people always focus on the antiparasitics, but these also have effect on other, so they have effect on bacteria, yeast, viruses, all sorts. They have a very common antimicrobial effects, a lot of these off-label drugs. In fact, I think most of them would have had some effect. All the ones I've looked at seem to have anti-COVID effects as well. So we'll talk about that a little bit more, but I'll just quickly whiz through. So my last edition of my book, I included a chapter on ferroptosis. Most people associate cancer cell death with apoptosis. Now, ferroptosis was discovered as something that happened in cancer cells. It's obviously always been there, but they didn't really focus on what was actually going on until 2012. But it's all about this accumulation of lipid peroxides. It's sort of rusting the cell membrane. And this seems to have much more efficacy than just trying to do apoptosis. Apoptosis tends to stimulate resistance in the cancer cells, whereas ferroptosis seems to have a much more efficient cancer cell death. Whiz through my history. So that's like a million years ago when I was first a physiotherapist. Don't want to talk too much about this. This makes me very cross, but I was under a doctor. About 19 patients died. There was a national recall. He's actually since been struck off. And unfortunately, I was in the wrong place at the wrong time. Really, it was terrible, and I let's not dwell on that because it just still makes me very cross. Should never have had cancer at all. So from 94 through to 96, I was battling the normal chemo, radiotherapy. I had a Vertime hysterectomy for the cervical cancer, and I was only 30 at the time. So this was devastating for me. I really wanted a family. I just met Andrew, and I wasn't married. I just thought I was left on the shelf. It was just truly, truly dreadful time for me. It was massively depressing. So I went through a very down period of my life. And then to cap it all, in 96, my mum ended up with stage 4 breast cancer. I tried at that point to look for things that would help her. This is when I started to discover things like intravenous vitamin C, and IGF, and low glucose, low GI diets. That all came into my approach at this point. But I didn't really, I kind of twigged that I was quite close to stage 4 because it had spread to a lot of my lymph nodes. But so it was a bit of a wake up call for me. But then in 99, I was diagnosed with stage 4. And at that point, we did a quick marriage. I literally found out on the Sunday. They'd finished staging me by the Wednesday. Thursday, I just said, let's get married on Saturday. So that's what happened. And that was really, that led to me just I called my cancer my spotted bother, which was what my mother called it. And then I put together a whole load of things that I was doing. I was like throwing everything at it, the kitchen sink, everything. I knew that I was terminal at this point. And cervical cancer, when it gets to that stage, is incredibly aggressive. And, I knew I was, and I have doctors in my family, and they went around telling everybody that I wasn't going to make it, which was great. But, there are a lot of things in there that are very useful. And I think a lot of integrative doctors incorporate a lot of things like this, like taking a thyroid and all of that stuff. Your gut health is absolutely critical. But it was in that year that I actually started going through journals. Back then, the internet was pretty sparse with information. So I was really finding all of my info through journals and magazines and things like that. So this was in the Journal of Herbal Medicine. I came across berberine. They didn't have it as a supplement back then. This was not even heard of. And in fact, I had to introduce this to my integrative doctor. But the thing, there are a lot of things about it that I thought were interesting, but it sort of had this starving cancer quality, which I thought was really interesting. So that sort of headed me off into that thought process. And so I started adding quite a lot of things into my cocktail. I mean, I had a whole host of supplements. They called me maracas on my sailing team. They thought I was crazy. But in 2003, I then ended up with treatment-related myelodysplasia, which was a result of having the chemo and the radiotherapy at high dose. So this was another cancer layered on top of the first one. And survival for the first one was bad, but this one tends to convert into AML quite quickly. And, it's a very short survival. So at this point, they tested various things. I had a deleted P53. I had the raised TM2PK, which showed that's a sort of a marker for glycolysis. Raised MMP2, that's matrix metalloproteinase. That's the ability of the cancer to spread. And my immune system was seriously depressed. And then I came across this article in the Townsend letter about dipridamol. Now, just a little bit about dipridamol. Yes, it's an antiplatelet drug, so it does stop the platelets sticking together, and platelet-derived growth factor is a really serious instigator of metastasis and spread. So it is important to look at some of these things, and I know that Dr. Marriott, you've looked at Viagra and Cialis and things like that, haven't you, for helping to stop the platelet aggregation. But dipridamol is also a nucleoside salvage inhibitor. In other words, it stops the cancer pulling in certain nucleosides. But in fact, something that it really stops, alongside with the adenosine, is uridine, actually. Don't know why it's not on that list, but uridine really drives pancreatic cancer. And I've seen some amazing remissions from pancreatic cancer using dipridamol as part of the cocktail. Right, so this is where, this is sort of a quick look at my map here. So the nucleoside salvage pathways on the glutamine side, And then it'll also help block this pentose phosphate pathway, which the Viagra and Cialis and all of those other PDE5 inhibitors also work on. So it also inhibits a cholesterol pathway. And this is what I love about these old drugs, is they're known as dirty drugs because they inhibit more than one pathway. They're like a multi-pronged approach all at the same time. And this is why they're great, because they can just hit different things together. And dipridamol will also hit this pathway here, something called SREB-P2, which is an alternative cholesterol pathway. If you block the mevalonate pathway with a statin, and cancers need cholesterol, they really need it. They need to build the cancer membrane, and they need to have cholesterol blobs on there. That's part of what they are. Without them, they're not actually a cancer cell. So they need to have these this fat pathway activated, and some cancers use this strongly, like pancreatic cancer, ovarian, breast, prostate. They all love this pathway, particularly in AML. But dipridamol, actually, I wouldn't use for most blood cancers because a lot of it can cause this bleeding, or so you know, it needs to be checked very, very carefully. But this is my cholesterol corner down here, and this is part of what I did. So I added a statin into my cocktail, and it also blocks this GLUT1 receptor, the statin. So I'll quickly talk about the pathways that it blocked. So with the statin, I then added other things as well into my cocktail. So that's the research that I came across. And then I found that if you added a non-steroidal, and I used etodolac rather than sulindac, and I actually took this information to my oncologist, and back then they didn't quite have the same strict guidelines that they do now, and she felt compelled, given my situation, to actually provide this cocktail, the two drugs, both as the etodolac and the statin, because she was actually, thankfully, she had actually just been investigating statins herself, but she didn't know which one might work. She was really pleased that I'd kind of shortcut a little bit of her research, and she said, right, great, yeah, I'll give it to you. You know, she knew I didn't have long. So by 2004, I was no evidence of disease. But in fact, actually, having said that, I kind of let myself go a little bit. I didn't take all the drugs all the time. I stopped because I didn't know what I was doing. I felt like I was a complete guinea pig, which I was. I didn't know anybody else who'd done this. I didn't know that they were going to have the effect that they did. But 7 months after starting my cocktail, all my markers went almost back down. They're not completely, almost back down to normal. I should have stuck with it for much longer. And then in 2004, I had a big birthday, went a bit crazy. And unfortunately, I kind of made it get worse again. And I was on my markers were going exponentially up. So at this point, I put my cocktail back together again. So in 2003, this was my basic cocktail. So the dipridamol, the etodolac, and these other things as well. But in 2004, these are what I call my big guns. Obviously, I was taking quercetin, curcumin, a whole load of things, green tea, etc. Lots of stuff to block different pathways. But this was including the berberine, which I think was critically important for me because I'd forgotten about it. I started it in 99, and then you know what it's like when you're a cancer patient, you're just bombarded with all this information. But I remembered it. I put it back into my cocktail. And after that point, I then found metformin, which I then entered in. And later on, I took cimetidine as kind of like something to switch on my immune system. So it's been a complete cocktail of things together. And Jane, here I am. I've been completely...
Dipridamol and NSAID is like your basic starting point, or has it...
No, I wouldn't say that would be what I would recommend to cancer patients. I think the research really backs, most of the research seems to back metformin and statin as the two, if they work together. In fact, metformin and statin actually work on the SREB-P2 pathway as well, less intensively than the dipridamol and statin. But
and you would combine with berberine.
Berberine I like. It has a lot of lipid inhibiting properties that metformin doesn't have, but metformin has other properties that berberine doesn't have. And in fact, it looks like the synergy of berberine and metformin together, particularly for non-diabetics, seems to be better, right?
So
but obviously,
there's obviously been a big, especially in our community, a push against statins. So people don't.
Yes, I'm well aware of that, and I think you need to separate cardiovascular problems from cancer, and this is
that's the point. We're treating cancer now. We're not treating cardiovascular disease.
Yeah, exactly. And if you have cancer, you have to change your priorities. If you don't have cancer, there are other things, like berberine is great for trying to reduce your markers for cholesterol, etc., or trying to improve your general health. And I still take a statin. Actually, I don't take it all the time. I do take a bit of CoQ10, and I make sure I'm sort of boosting myself. And CoQ10 does have some anti-cancer effects, but if you take, one of the reasons that statins works is it lowers the glutathione and the CoQ10, and actually creates a pro-oxidant environment, which is better because that works better with chemo, and it actually works to stimulate ferroptosis. That's the point. So statins actually seem to be quite important for ferroptosis. And once you don't have to take them necessarily forever, but I would say pulsing them would be the way to go forward with it. And I do think they are important. In my view, they seem to have the best effects for stimulating an overall result. But
so would you recommend a statin for most cancers then?
Fibrates also can be particularly important. So there are some cancers that are driven by a different fat pathway, more of the SCD1 pathway. And fibrates, in fact, actually maybe a lower dose of each. Again, it would have to be carefully monitored by the doctor. You don't want to risk sort of muscle problems coming up with this. But the combination of fibrates and statins, and the best statin seems to be actually pitavastatin. That has less muscle influence. It doesn't have the same interactions with other drugs that some of the statins do, like simvastatin. It's a lipophilic drug. So these are lipophilic statins. You can't just have any statin. They don't all work, right? So pravastatin is a hydrophilic. So it's water-loving, doesn't work for cancer, right? But the lipophilic ones do. So atorvastatin, lovastatin, simvastatin, and now pitavastatin, which seems to be this new superstatin. And in fact, they've shown that in ovarian cancer, pitavastatin is really key. So ovarian cancer loves the mevalonate pathway, which is what the statin stops. And they found out that, and I was talking to Professor Richardson at Nottingham University about his use of ivermectin and a statin together. They seem to be synergistic for ovarian cancer. So they were trying to get the level of pitavastatin to work against ovarian cancer. And they found that if they added ivermectin, the result was much better. So I asked him, I said, why did you add the ivermectin? And he said, well, my researcher is from Iraq and they use ivermectin for everything there. So I thought, well, I'd let him have a go and see what happened. I thought, well, that's a good enough reason for looking at a good combination, but it works. So the combination of, and there are probably lots of other things that would actually make and we know that's the case. And I think actually the dipridamol statin combination could have been even better for ovarian cancer. So it's a sort of a layering, it's a synergy of getting things to work together. And the one thing I want people to take away from today, and I haven't quite finished my presentation yet, but the one point that I really want people to understand, it's not just about one or two drugs. There's this big push for ivermectin and fenbendazole at the moment, and I can understand it. They're relatively easy to get hold of. You don't need a doctor's prescription, but it just worries me that people aren't looking at the right pathways. They're not using the right thought process to try and work out what they really need. And I think the success of my book has really been people using my Metro map as that navigational tool in order to work out exactly what it is that they need. And it has seen quite a lot of success, but it needs updating. I need to do the next one. So my thought process going through creating my Metro map started off with just this very basic thought of blocking those 3 macros in the diet. And this is kind of like what I call my Piccadilly Circus theory, where you're looking down on Piccadilly Circus. This is like the oncologist looking at what's going on. They are focused on the genes, right? They are focused on the P53, the BRAF, the KRAS, whatever it is. These are kind of like the main fuel lines. I'm likening it to sort of all heading in to Piccadilly Circus. But this is my underground map of what's going on in Piccadilly Circus. And these are the metabolic processes. These are biological processes. These aren't genetic processes. These are things that the cell will do. It just has this ability to use different pathways to go around and switch and change. If you can't get to Piccadilly Circus through the Bakerloo line, you're going to go up the Northern line, you're going to go, like, you've got all these different routes that cancer will use, and sometimes they have to take a long route to get around to Piccadilly Circus. But this is the point, is that cancer rewires, and this is why we have resistance, we have treatment problems, and people fail because their cancer doesn't react properly to the chemo, the radiotherapy, the immunotherapy, whatever they're on, tyrosine kinase inhibitors, because the cancer is rewiring its metabolism. These genetic changes, the KRAS, the MYC, the BRAF, whatever, they have effects on the metabolic processes. And I've tried to empower the cancer patient to understand what's going on so that they can sit in the driving seat and they can go, right, you can use AI today. I'm like, it's just genius. It's so easy to kind of work out what you need to do compared to me back in 1999, floundering away, desperately searching through endless journals. The dipridamol information came from a 1985 journal. It was crazy amount of research that I was having to do, but it's kind of like, it's easy today. It's so easy. You can just use your phone, type a few things in, and you come up with some really great information. It's getting better. It's still not perfect, but I feel like for the last 2 years I've been teaching AI. I feel that's been my job, to actually provide information, and I don't mind that. I want people to know this stuff. It's important. I've been trying to create links to make it look at the right kind of information, to look at it in the right way. So this was kind of me building up my map, and I was looking at different ways to block this ATP and how the cancer was using these different pathways. Autophagy is a double-edged sword. So for most early cancers, it won't necessarily use autophagy, but as you get more aggressive with the cancer towards stage 3 or 4, the cancer will switch on this autophagy. So it will pull in, it'll actually recycle dead cells to feed itself. And this is how it survives. So autophagy also needs to be blocked too. So there are multiple different ways, and people get a little bit stuck with this OXPHOS pathway because people feel that you shouldn't have to block that. And I know Tom Seyfried is against metformin, and he doesn't like anything that's going to affect the cancer cell mitochondria, all right? Because this is something that happens in the mitochondria. This happens in the cell cytoplasm. So this mitochondrial action, actually, people don't realize there's a reverse Wahlberg that happens in a great many cancers. And you can look this up on AI. You can type in, does my particular cancer use more OXPHOS or glycolysis? And you'll be surprised to find that there are a few cancers that are actually using more OXPHOS than they are glycolysis. Because what happens is you have the cancer cells are actually using OXPHOS, but they've transformed the stroma, which is around the cell, to be using glycolysis. So this pumps out. So the glycolysis, the stroma is pumping out lactate. The cancer cell is converting that back to pyruvate and pumping it back in through the mitochondria and then producing 36 units of ATP. So it's actually driving the cancer in a different way. Breast cancer, estrogen positive breast cancer, for example, uses this. So this is a really important, this is why we need to curb this particular action. And in fact, what happens is the cancer cells nestle up to the cells in the stroma, and it's a bit like pirate ships. They sort of like lower the drawbridge, go over, nick the mitochondria. They will actually steal mitochondria, pull it in to the cancer cells. So they got the treasure, get it back on board, and then they have a much better fueled cancer cell for division and fueling progression. So this needs to be curbed. So you have this excess of mitochondria. The mitochondria also have their own DNA. They divide, they create this super fueled cancer stem cell. And this is what we need to stop. So in fact, for breast cancer, you'll find that doxycycline, which is an antibiotic, will work on, because mitochondria are like whole bacteria. So berberine is actually a natural antibiotic. So that's why it works really well on this OXPHOS pathway. And in fact, you'll find that ivermectin is a weak mitochondrial inhibitor as well. So it does actually work on this pathway too, but you need to have a combination in order to, so metformin is only a week, they're all weak, but you need to add these things together to get a stronger effect, a bit like using the ivermectin and the statin together. The combination of the two creates the synergy that works better.
So Jane, you mentioned doxycycline. Can I just for a second? A lot of people are reluctant to chronically take an antibiotic because they think it's going to alter the flora and the microbiome is so important.
Totally understand that. Yes, and but you also want to stop the cancer. So the Care Oncology Clinic, which we'll just come to in a minute, they added, so this was their cocktail and doxycycline was in their cocktail. And I think if you have a colorectal cancer or something which is directly linked to, really, I mean, they all are. All cancers are linked to the microbiome and things going wrong. That's kind of like the root source of the problem, the immune system and the microbiome. But the doxycycline is effective, and they used it for a month on and a month off. So they'd allow the microbiome to recover in that month off. You can also use things like Saccharomyces boulardii, things like that, which are a yeast, which doesn't get affected by doxycycline, and that will help keep the microbiome going whilst you're taking the doxycycline. Or you can take probiotics at a different time of day to the doxycycline, so you can kind of keep it going. And it's just a juggle. Always trying to get yourself better.
Doxycycline, out of all the antibiotics, seems to have the least effect on the microbiome. Is that correct?
Yes, it affects more of the small intestine rather than the large intestine. So that's why you get less of effect on the microbiome. But I still think it's worth boosting your probiotics for fiber.
And so do the patients take it chronically, or do they alternate month on, month off?
They tend to, if they're going to do it, some patients are given doxycycline, and I think a lot of Lyme patients actually take doxycycline all the time. But most of the patients will take it a month on and then rotate off. In fact, they're rotating the mebendazole for 1 month and the doxycycline for 1 month. They're just alternating between the two. But I do think that given they both have huge anti-cancer effects, but they work in different ways. In fact, they both, mebendazole and doxycycline, will work on those matrix metalloproteinase. They both stop those growth factors together. So actually, that's an important point with them as well. They don't just work on starving cancer, they'll work on the growth factors too. This coming back to my Metro map was where you have, and this isn't a full map, this is just a quick basic recap, the first one I did in 2018. So statin and quercetin will block the GLUT1 receptor. Now, different cancers use different glucose receptors. GLUT4 is your muscles. That's what your muscles use to get glucose into them. Cancer uses GLUT1. Some cancers use GLUT2, GLUT3. A few of them will use GLUT4, like myeloma. Many cancers actually use the fructose receptor, which is GLUT5. Right, prostate cancer, breast cancer will actually use GLUT5. So you have to be a little bit wary about that. But apigenin, which you find in parsley, and I think it probably is better taken as a pill because you get a much more concentrated effect, can actually block the GLUT5. So there are lots of, throughout the whole of my MetroMap, there are different ways you can actually block the effect of cancer getting in and fueling and driving the cancer. So this is my project, right? I've been a complete nerd for like years, just trying to map out what was doing what and actually creating this map. And people are now using this as their navigational tool to try and work out for themselves. And with AI, I think it's just a game changer. It really is. So for me, it's a big relief because I've had, it relieves me of the stress of having to deal with it, because I know patients are much more empowered themselves these days to actually go ahead and work it out on their own. They shouldn't just work it out on their own. And this is why I want to create an app, is to try to create an easier route for patients to have information they can produce, which they can then go and take to their oncologists and say, these are the pathways that have been blocked by these things. And to have the ability to talk between, and I think this is the future. We need to get oncologists and integrative doctors working together. I know there's a lot of conflict out there, a lot of resistance to these repurposed drugs, and I know this is kind of like a little bit of an I told you so moment with ivermectin. But I just feel that we need to embrace, in order to get where I want, which is more people surviving, we need to encourage the oncologists to come on board a little bit and to understand this. And it's I felt like it's my mission to try and, I don't think I will ever change the oncology profession, but I hope I will just change their attitude to try and embrace the metabolic approach, because it's so cheap, really. I mean, some of these things I was just looking at a cocktail which I put together for a leukemia girl who's doing phenomenally well. This, hopefully I'll get some press coverage next week. But anyway, it's the cost for the NHS, I was looking at the cost, it was £15 a month, right? Treatment for this girl. £15, that's all, like, I don't know, that's about $20. Nothing. It would cost the NHS to provide this. And it just makes me really cross that we don't have the option to put this together. So I said I was going to talk, Dr. Merritt, a little bit about the antiparasitics, because this is the topic du jour. A lot of patients out there are putting these cocktails together. So ivermectin and mebendazole do stop this glucose receptor. In fact, ivermectin seems to block more of GLUT4. I don't know whether it blocks other ones. Mebendazole seems to be much more of a global glucose blocker. Okay, it stops the tubules pushing out the glucose receptors to the surface. Ivermectin, just move this a minute. Ivermectin and niclosamide do work on this OXPHOS pathway. Very important for some cancers. So we need to look at that. The mebendazole does block lactate dehydrogenase. That's one of the enzymes in the glycolysis pathway. So it does work on that. And then you have on the other side, on the glutamine side, mebendazole and fenbendazole do actually modulate this proteasome. But you need to, for the anti-cancer effects, you need to add bortezomib as well, just to make it work better. But to block glutamine is one of the things that people find really hard. Now, niclosamide blocks this macropinocytosis pathway. This pathway is really, really upregulated again in pancreatic cancer. Right, I have so many pancreatic cancer patients.
So, Jane,
really well.
You think we could stop at this point? I have a few questions to ask you, and then
far away
over to the audience. So maybe I know I'm cutting you short, but we don't have a lot of time.
Fine. I think I'm pretty much done.
Yeah, I think you've gone through the map pretty well. So one of the things you really didn't focus on was diet and low glycemic diet, and that's absolutely critical. I have 4 pillars in my approach, and
diet is something which I think is really key. Now, it doesn't matter really it does matter. You can choose between ketogenic diet, intermittent fasting, or a paleo diet. All of these things will actually reduce the amount of glucose getting into the system, right? So there are certain times or certain patients who need to be evaluated properly for the ketogenic diet. Doesn't work in everybody. It can cause cachexia, and I think you need to have a nutritionist really evaluate you for your insulin resistance and all of that. So clearly insulin it's on my map as well. Insulin is a really big kicker. It'll drive and push the glucose into the cell. So really important to be looking at insulin and lowering your resistance. And in fact, metformin combined with fasting, intermittent fasting, seems to be the way that it works better. So there was this big HA23 trial looking at metformin with breast cancer, and it was like deemed to be a failure. But what we know is that metformin works well with diabetics, right? But they did this test on breast cancer in non-diabetics using metformin, and of course it didn't really work that well, because again, you need to layer these different things in. All of these drugs on their own don't work very well. You need to have them in combination, and what worked was the combination of metformin. Well, they're doing another trial looking at intermittent fasting and metformin for breast cancer these days. So but it's not a very big window. That I think they're stopping the feeding at like 8 p.m. until 8 a.m. I don't think that's long enough myself. So, I think you should be stopping earlier and starting later the next day in order to get a bigger intermittent fasting window.
Yeah,
but they're
so
now looking at
I agree that intermittent fasting at least is a very basic component. So,
Yeah.
I was speaking to a patient who is a physician who had metastatic disease, and she said, she has a vegetarian diet. She eats really well. She eats vegetables. I then pushed her a little bit further, and she ate like 5 meals a day. She snacked at night, and she liked her pasta. And I said, you know what? Those are the worst possible things that you can do. So it's really important to exclude high carbohydrate diets, processed food, glucose, because you want to starve the tumor. You would agree with that?
Yes, you do. Absolutely. It's absolutely paramount. You should get your diet right. And the first thing, actually, sometimes that ketogenic diet will help kickstart you into a better diet. And you know what? GLP-1 agonists, if you're really struggling, take them at the beginning until you get maybe into a better pattern. And they have shown that GLP-1 agonists will actually help reduce colorectal cancer rates, etc. So, this is another emerging factor that may come into it. But of course, the cocktail, the polypharmacy of using different drugs together, because of course, these things have some potential side effects as well. So it's all about having a safe cocktail. And maybe at the beginning, if you just want to get into that kind of better approach, maybe you go and have a GLP-1 agonist to start. You say, please, I need to curb my diet. I need to be having a better diet. And it stops you from eating some of those, the pastry type of things. So this is important. And I do think it's something we should layer in. They are miracle drugs, and I think we should embrace the fact that this could be very useful for some cancer patients.
Yeah, so I must agree. I think GLP-1s aren't the answer to the obesity pandemic, because that's just people gluttonously overeating. Yeah. But I think people who are trying to do intermittent fasting and are struggling, it's a way of kind of kickstarting their diet.
Exactly. I think a lot of people need help. And why deny them that help if it's going to just get them over that line to once they understand what they need to do. I just think people do. Cancer is complex. It's not going to be easily fixed with one thing or another. It's always going to be a cocktail. So that's really what I'm trying to achieve, is to get doctors to look at beyond ivermectin and to actually look at the bigger picture of everything that's going on in the cancer cell, and to look at some of these cocktails to see, if we can get better results for people.
Yeah, so I think I must agree with you that, just mebendazole or fenbendazole alone is not, is not going to cut it. That you need a combination of different drugs that act on different pathways.
Yeah.
So what would you say is the minimum amount of drugs that they need, or do you adapt it according to patients?
The more aggressive, the worse the stage, the more you need to attack it, And I think if you are stage 1 or 2 and you've got breast cancer, go for a bit of doxycycline. I mean, Professor Lazanti was looking at just a cocktail of some antibiotics. So he's using azithromycin and doxycycline to push on that reverse Warburg effect. And then he was using berberine as well. And then he was looking at vitamin C to block the glycolysis. It's like you need to block both of them, both the oxphos and the glycolysis together. And he got really good effects just with stage 1 and stage 2, just looking at that cocktail. But there are, I think you just need to, I think metformin and statin actually are quite critical. If you are more advanced, you absolutely need to look at adding more. And there are, prostate cancer, pancreatic cancer, breast, ovarian, they all are colorectal, driven by these fat pathways. So I don't think you should rule out putting a statin or a fibrate or, the dipridamol. You just have to learn what drives different cancers, and the information is out there. It is, and it's much easier to find these days. So I'm power to everybody. You've got this.
But just going back to statins, what kind of dosage do you, I know you don't prescribe, but
no, I can tell you what I did and what the Care Oncology did right at the beginning. They were prescribing 80 milligrams of atorvastatin. I took 80 milligrams of lovastatin, and I actually think that their results were better in the early days when they were doing that than they are now. Well, the COC is effectively disbanded, but before they disbanded, the results, I would say, were better when they had higher doses. But it may be that you need to lower that dose and add a bit of fibrate or add a bit more berberine or something or a bit of niacin even, that's actually going to help block those fat pathways a little bit more as well. Dan Shen, by the way, blocks that CD36, that's red sage, and that's really important for blocking this uptake of fat where, and I'm talking about the 3 antiparasitics in my earlier slide, where you've got the ivermectin, you've got mebendazole, and you've got niclosamide. I think niclosamide is brilliant, and I think it is so underutilized right now, really underutilized. And it blocks glutamine, like you're blocking lots of glucose pathways with the ivermectin and the fenben or mebendazole, but you are not blocking the glutamine pathways effectively, and that's what worries me. And I can just see that if just adding some more of these glutamine inhibitors would really push the results up. And I want to collate these results, and I'd love your help with this, please. Dr. Merrick. So collating, just bringing some stuff to me. So for my PhD, so that I can actually just report on these cases and actually try and prove to the world that this really does, this is actually a viable route forward, and try and encourage doctors to come on board. And I have a list of doctors who follow me and who follow my approach on my website. I want to add more. And I don't just want to add the doctors who just do the ivermectin and fenbendazole. I really want doctors who will look at bigger, better cocktails for their patients. I think you're very limited just by, they will have effects and some people do well, but, I just want people to do better. And that's the important bit.
Are you saying that most of the patients should be on a combination of metformin and a statin?
I think, in a word, yes. I do think that that would encourage other pathways to be blocked. So yes, I think that would, yes, I would.
So Jane, maybe at this point we can hand it over to Autumn, and I'm sure there must be some audience questions that we can try and answer.
Yes. Hi, Dr. Merrick. Hi, Jane.
Hi.
As Dr. Merrick mentioned, my name is Autumn, and I'll just be sharing a few questions with the audience. One question that I wanted to start off with, one of our senior fellows asked, Jane, how do you maintain your remission at this point?
Right. Well, I went into remission in 2004. Cancer cells have not come back. I mean, I didn't, I do still take dipridamol at night, a statin mostly, and metformin I take during the day still. I still have a relatively low glycemic diet. I'm not as good as I was. I was really on it when I was going through cancer. But nowadays I'm a bit more relaxed. I know I can switch it up if I ever need to. And to be honest, until COVID, I was still checking my cancer markers. But since COVID, it just became a nightmare doing anything. So I haven't actually done that since. I'm just relying on the fact that I feel okay. And there were always that sort of, that scanxiety and results anxiety that you always get. I haven't had scans or anything for years. I'm just hoping I'm okay. I haven't looked at any other kind of markers. I haven't looked at biopsies, blood biopsies or anything like that for checking for stem cells or anything like that. So I think I'm okay.
But you are still taking some...
Yes, I am, absolutely. And I take quite a lot of supplements still. I still drink green tea every day. I hate it, but I still drink it. I think it's important because that helps again to block the glutamine getting into the cell. I'm aware. I think once your eyes have been open to this, and once you've been stage 4, and I had no idea I was going to survive. I was on death's door. And once you've been in that situation, there's no coming back from it. You can't unlearn it. So now I am very careful about my diet still. I'm not the best anymore, but I'm still fairly cautious about what I eat, and I still add quite a lot of the off-label drugs into my cocktail.
Another question we got from Bob Isaacson was, what is known about the accelerant effects of electromagnetic energy, X-rays, microwave radiation, etc., on cancer growth? Is this something to avoid when one is diagnosed with cancer?
Well, there are pros and cons, aren't they? I mean, this is not my specialty field. But, I would for me, when I was stage 4, they wanted to take CAT scans of me every month because they wanted to see how I was doing. And I refused to let them do that. I said, no, you're going to take a scan of me every 6 months. I was very confident I was going to be around. They weren't confident I was going to be around. But, I do think we have to be very careful. Mammograms, etc., can be... I don't have a mammogram very often. I've only ever had one. I like to keep the amount of radiation down to a minimum. I mean, we can't avoid those cosmic rays, So it's hard because the environment's tricky, and your work may expose you to all sorts of different toxins and carcinogens and things, and it's you have to tiptoe your way around everything and just do what you can. And I'm not saying don't have those mammograms. For me, I just feel like I'm doing enough to I check my breast properly regularly, and I think I'm okay.
Dr. Merrick, do you have anything to weigh in on that question?
Well, to avoid as best one can. I mean, especially CAT scans, because a CAT scan is like equivalent of 1,000 X-rays, and radiation exposure from medical radiation accounts for about 5% of all cancers. So yeah. CAT scans and all these scans actually cause cancer, which they're trying to detect. So, try and avoid them as best you can. And as Jane said, only do it once if it's really needed.
Another question we got for you, Jane, was from Bob Fox. He asked, what AI engine do you use for your research, or which one do you prefer?
I actually like to compare a few of them. So I I use Perplexity probably the most. But I also use Grok 4, and I also use Consensus for looking at for deep searches into literature. So lots of different things, but I'd say Perplexity is probably the one I use the most, and Grok 4, I compare the two really. ChatGPT 5.
So I must agree with Jane. We've looked at a few of them, and we really like Perplexity. I think it's very scientific. It gives you the true facts. It gives you the references. It is sometimes useful to compare different ones, but I find most of the time Perplexity actually gives you the truest answer.
Yeah. Yes. And I asked some questions about me and I see what the results actually say. And, I think Grok 4 and Perplexity definitely came out on top with getting the information right, but it's not perfect. They don't always. So, I will ask them certain things and they'll get the wrong drugs that I took. So I don't know.
So I think the answer is most of the time it's correct, but you've got to cross-check the reference.
Yes, and I'm constantly, and I think, okay, it's learned. I've told it what I was taking, but it still gets it wrong. So I don't know. I don't know how good its learning really is. So who knows?
Last question before I move on.
I think somebody's asking how to access Perplexity. You go to their website.
Yeah, perplexity.ai.
Yep.
Yeah. And so there is a free version, and then I think there's a paid version.
Yeah, you can go pro with it.
Yeah, the pro, which gives you somewhat more detail. And they see.
But you can get a few pro searches on the basic one. They give you, I think, 3 a day or something.
Yeah.
I can't remember. But anyway, I pay for the pro.
One last question. We were receiving questions about lowering glutathione specifically, whether it's recommended in all cases or whether people should avoid supplementing with it, or this if this guidance only.
Yeah, that's an interesting question because NAC, the N-acetylcysteine, which creates glutathione, again has sort of differing results. So if we take ovarian cancer, for example, some subtypes will respond well to having a tiny bit of NAC, and some more aggressive ones won't. So, and it is very variable depending on what you're doing. So, and it's also down to the timing. You don't want to be taking this just before you have chemo because it's going to stop the chemo working, but you do want to take it. There's research to show that if you take it 5 or 6 hours after your chemo, you're going to protect your healthy cells. So you've already killed off some of your cancer cells, but you want to protect your healthy cells. So it's a timing issue and how much you take. Now, glutathione itself is different. I would generally say avoid it at particular times, and it can fuel. I've seen people do quite well initially on NAC, but what they do is then drive resistance because you're driving that antioxidant effect, which means you can't stimulate ferroptosis. It's like it stops ferroptosis from happening. So you need to be blocking that, and that's why things like.
Yeah, so I think as a general rule, you want to you want to avoid antioxidants because particularly when you're having chemo or whatever, it negates the effect. The other thing which is really interesting is B12. So high levels of B12 actually drive cancer growth. So if you're taking B12, one has to be really cautious and make sure your levels are low. So obviously metformin can cause B12 deficiency. So people often take B12, but if you overdose, it actually drives the cancer. So one has to be careful about these interactions.
Exactly. There's a window, a sort of a B vitamin window, I think, that people need to be aware of. And if you're under or you're over, you can cause problems. But yeah, B vitamins are important.
Well, before I move on to our closing announcements, Jane, Dr. Merrick, is there any closing thoughts that you'd like to leave our audience with?
So I just want to thank Jane. I think she basically was the engine that has driven a lot of people down this pathway. There are multiple different approaches. I don't think there's a right approach, but I think Jane started people down this track of, repurposed drugs and alternative therapy, which is really very important. And,
Thank you.
I think with time, we're going to refine what we do. There's something like 300 repurposed drugs that may have activity against cancer cells. And obviously, you can't take 300 drugs. So I think with time, we're going to refine what we do.
Exactly.
It's really through collaboration with people like Jane. And so I think her book is really, for anyone who has cancer or knows someone with cancer, is really a good starting point to read, because it's a very good book, and it's a very touching book, and it's a very personal book.
It is a very personal story. But yes, I think actually you're going back to, if I can revert back to Dale Atkinson at the beginning, he said it lit the fire underneath him to actually drive him to beat this thing. So, and that's what I want to do. I want to light that fire and to prove to people that it is possible to overcome even stage 4. I feel like I'm constantly having to bring people back from the brink. I mean, for me, the best time to be adding these repurposed drugs is right at the beginning, when you're first diagnosed. That's what I would love to see in the future, is you go to the oncologist, you're diagnosed, you literally come out of that consult, you go and see your GP, and then the GP provides you with a cocktail of drugs, right? That would be my ultimate mission completed if that happened. I think we are probably decades away from that. But this is what I want to do, is to create more information so I want to collate the info, and then what that will do, I want to sift through that and come out with the better cocktails and the more information, and maybe we can work on that together, Dr. Marek, and look at creating something together to do that.
Book, How to Starve Cancer, which is really the ultimate goal. You want to starve cancer, and so you can get this book. Fortunately, I checked today, it's available at Amazon.com. So it is available.
So my second edition, so you can get the first edition. The second edition is actually called How to Starve Cancer and Then Kill It with Ferroptosis. So I've got that new chapter on ferroptosis. And every time I speak in the UK, they kind of punish me and take my book down. So they did it a year ago when I talked at the Yes to Life charity event. And I got my books back up again, not my second edition, but I got my first edition back up. And then I spoke again this year. They took my book down again. So to find my book, my second edition, you can go to my website, which is howtostarvecancer.com. Keep an eye out for my third edition, which will come out next year. I've got a few more things on the pathway, but hopefully by then AI will be even better and we can work out, and hopefully I'll have an AI tool that will also help you determine what will be best for you as well. It's all going to be part of what I want to do going forward, is create easier, better resources for people to do this and hopefully collaborate a little bit. But we don't like this conflict, right? We don't like the fact that patients are hiding stuff from their oncologists. We want open, honest discussions, and that's my mission.
So thank you, Jane. It's been a pleasure having you.
Okay, I've loved it. Thank you so much. It's such an opportunity for me to speak to your gang. I've wanted to do this for a long time. So thank you so much.
Thank you. And thanks, Autumn, and the rest of the team.
Yes, thank you, Dr. Marek. Thank you, Jane. I will move on to our announcements and keep it quick. Have a good night, you two.
Thank you.
All right, so some exciting news. Our upcoming IMA conference tickets are now live. This is very exciting. We hope that you will join us for 2 powerful days of learning, connection, and collaboration with clinicians and researchers from around the world. You can get those tickets at the link on screen, imahealth.org/conference. For those of you that would like to go deeper onto tonight's topic, one, be sure to purchase Jane's book, and also you can visit our new Cancer Care Hub on the IMA website. On this page, you'll find a wide range of resources, far too many to list here, but if you scroll down, you'll also see Dr. Marek's comprehensive cancer care monograph covering metabolic health, repurposed therapeutics, supportive nutrition, and much, much more. That link is imahealth.org/cancer resource hub. Next week, we hope that you will join us on Wednesday, December 10th at 7 p.m. as our IMA Senior Fellow, Dr. J.P. Salibi, hosts a special webinar discussing peptides, featuring IMA Senior Fellow Dr. Molly James and possibly other guest experts as well. In this episode, they're going to be breaking down what peptides are, how they work, the pros and cons, and why they're becoming a widely recognized tool in regenerative and metabolic health. Trust in healthcare is broken and patients are feeling it. That is why we at the Independent Medical Alliance are in the process of building the IMA Trusted Referral Network. This is a national directory of vetted independent clinicians who truly listen and put patients first. Your year-end tax-deductible gift could help us build this secure platform, onboarding ethical providers, expanding features, and really to roll it out nationwide. We helped hundreds of thousands find care during COVID, and now we're building a stronger, permanent network for cancer, chronic illness, brain health, and more. We hope that you will join us in restoring trust in medicine, and you can find that link on screen or by visiting imahealth.org/restoring trust. All right, well, thank you all so much for joining us this evening. Before we close, we wanted to share a clip from We Unify, a conference. This is a panel discussion featuring Dr. Charles Hoff, our co-founder, Dr. Joe Verone, and IMA Senior Fellows, Dr. Ryan Cole and Dr. Jennifer Hibbard. In this panel, they were discussing medical ethics and informed consent. As always, we deeply appreciate your support, your questions, and your commitment to honest medicine. On behalf of the entire IMA team, thank you so much. Good night, and we'll see you next week.
I think a critical place that the medical profession went wrong was to abandon medical ethics. Every doctor and nurse and healthcare provider should know that it is never, ever right to force anybody to have a medical treatment or a medical test that they do not want. And this is the medical profession. I mean, this is a foundational thing. It's called informed consent, where you tell people the risks, the benefits, and the alternatives to whatever needs to be done, and then you allow them to make the choice. And in COVID, for some bizarre reason, the medical profession abandoned this foundational ethic that is basically personal bodily autonomy. The Code of Ethics and Professionalism of the Canadian Medical Association, which entrenches informed consent, also entrenches that it is never, ever acceptable to cover up evidence of harm. And I wrote to our provincial health officer, Dr. Bonnie Henry, to tell her the harm that was happening to my own patients. And I pointed out to her that whenever some new experimental treatment is being tested, if there is evidence of harm, you're supposed to stop the experiment. So I asked her whether it was ethical to continue the vaccine rollout in view of the evidence of harm. And of course, I was called a spreader of misinformation. So I think those are two of the foundational mistakes that we made as doctors and nurses and medical professionals in COVID.